teaches at the School of Nursing at Texas A&M. She's a pediatric nursing specialist. And is on our board of directors here at Voices for Children, so we're really happy to have her. She does this session for us every training. Not only is she going to teach you about the theory of attachment and what that means in kids, but she's also going to give you some case studies, so that'll be really helpful. After this, so remember, just 3 bathrooms, so take a break when you need to. At 6:30, Dr. Adam Sines will be here. He's a licensed psychologist who'll be here about boundary setting. And setting good limits with the parents and children that we work with. All right, and then at 7:30, we're going to do a little activity. That'll be fun. All right, got to get out of your way. Thanks, Allison. Do you want me to shut that door? Is that too much light in your eyes? Is
Are
everybody
you guys
okay?
okay? It doesn't bother me. Are you guys okay? Does everybody have this?
Yes.
Okay, super. Well, howdy. Please call me Allison. The reason everybody here makes such a big deal about Dr. Fitness is because I just became Dr. Fitness, so they like to call me that because, I finally finished. So I'm just so pleased to see so many faces and so many new volunteers. We are just so thrilled when we get a new class, especially a big one, because the need never ends for us to have classes. And so I just want to commend you on making this a commitment. It is so hugely important and so rewarding. And I'm just thrilled that each of you are here. I know you hear that from every person that you tell that you're doing this training, but it really is a very, very special goal, and for you to commit to it is very meaningful to the kids that you will be serving. So add my name to the list of people who admire you for what you're doing. To give you a little bit of background on where I'm coming from, I come from a little bit of a different direction than maybe some of I do serve on the board of directors for Voices for Children, but my direction comes maybe a little bit different. I'm not a former CASA, and I haven't worked in nonprofit, but I come from 13 years of being a pediatric critical care nurse. So I have seen kids who have been victims of non-accidental trauma and abuse, and we tend to see, people in my profession tend to see those kids on their worst day. And then when they leave us, they go into the foster care system. So that is really where I come from, a slightly different direction. And I'm learning more about this aspect of it, the community care aspect of it, coming from that. So I really have always, when I went to nursing school, I always knew I wanted to work with kids, and everything I do is pretty much centered around children. After being a bedside nurse for that long, I now teach nursing school. So I teach in the BSN and the MSN program at Texas A&M. We do have a College of Nursing. Nobody knows about it, but we're out on Highway 47, and so I teach our students about attachment and growth and development in children, and that kind of centers everything that we do when we do pediatric nursing, and it really will help you all, I hope, to kind of understand how kids develop and how they develop attachment. So I saw one of the questions in the bag was, I'm worried about getting attached to the kids that I work with, and that is a very real concern. I think our next speaker will really help you guys from that direction. What I'd like to, and it really kind of blends well, because what I'd like to talk about is attachment theory between child and parent, or child and caregiver, and how that kind of works into what we do and how we understand what goes on when there's neglect, abuse in the family, and how that affects the child and their development. Okay, so that's what we'll talk about. Any questions before we get started? Well, let's kind of start with some goals. We're going to talk about the concept of attachment, so you kind of understand that parent-child attachment and what that means. We're going to be able to kind of identify some of the signs and symptoms of healthy attachment and also of unhealthy attachment. And we're going to talk about resiliency. My favorite thing is the amazing resiliency of children and how they tend to overcome some of the difficulties that life throws at them, and also typical reactions of children and parents to separation and loss, which is a big part. Every single child that you will come in contact with in each job is experiencing separation. Separation from parents, separation from siblings maybe, separation from their home, their pets, their friends, their school. So that's a big part. And then kind of all this underscores, there's not much we can do when we have a child that really needs to be separated from family, but we want to return them to permanence. And this concept of attachment just is a foundation for why that's so important. We need attachment as humans. So that kind of ties into our next statement here, which is that human contact is essential. We are really, we look at chimpanzees and apes, and they live in colonies and they form attachments, but we are the ultimate species in terms of we have to be in touch with other humans in order to thrive and be our best selves. And so that's one of our biggest things that sets us apart is we can form many different types of relationships. And one of the very important relationships that we form is the one between parent or caregiver and child. So that physical human contact, that emotional contact is just essential to us as humans. So when we talk about attachment, we're really still finding out how important attachment is. It really wasn't a big concept and one that we really understood or defined except for in the last 50 to 60 years. So we know that we can define it as a special bond that forms between the primary caregiver. It doesn't have to be the biological parent, but the person who does primary care of the child and the child itself. And it can also talk about other, emotional relationships between spouses, friends, other things. But what we're going to talk about today is parent-caregiver-child attachment. And the key things that make it important is it needs to be long-lasting. If the child is separated from the parent or caregiver, that evokes some type of distress. Okay, so being separated, like being put in foster care, will always, if they have an attachment, whether it's healthy or maybe not so healthy, it will always evoke some response of distress. And that thirdly, the child finds some element of safety and security in that relationship. And you will see in this profession that there are times when a child may be removed from the home more than once, and we know a lot about that parent and maybe the experiences that they've exposed that child to, and we think this is a good thing that for right now this child is separated, but over and over again the child will just be devastated that they're being separated from their parent. No matter how good or how not so great of a parent that person is, you'll be amazed at how much children, no matter what kind of experience they have in that home, they want to go back. They want to be with their mom and their dad. So those are kind of, even though it may not be secure in our eyes, the child finds some sense of safety and security in that relationship. And some interesting things about this is that a lot of research on attachment tells us, particularly because they've looked a lot at the maternal child or the maternal infant relationship, because in our society, especially with if mom is breastfeeding, there's a lot of extra bonding that goes on between mother and infant, that relationship forms the basis for all of the relationships that we have in our lives. And the other thing is that a healthy, solid relationship with a primary caregiver is associated with healthy relationships in the rest of our lives as we grow and develop. But if there's poor attachment between infant and primary caregiver, that we have much more incidence of emotional and social problems with relationships later. So, let's start with the very beginning, when we are born. Now, there's research about attachment in utero, that before we're even born, when we hear our mother's voice through her body, we form an attachment and identification of that voice. There's research that shows that the spouse, the other parent, the father, or other, even if it's same-sex marriage, if there's another spouse and that voice is exposed to the fetus in utero, that they have some kind of identification. They look at their brain and do MRIs and stuff and see that they identify and recognize that voice. So there is bonding that happens before we're even born. What we know a little bit more about is after we're born. And from birth to about 2 to 3 months, and this may be a little protective mechanism that nature, our creator, has provided, is that we'll attach to anybody. Anybody who gives us any kind, meets our needs, gives us food, wraps us up, changes our diaper, we will attach to them. We definitely have a separate and more intimate bond with a biological parent that we spend time with, but if that person's not around, we can attach indiscriminately. At about 2 to 3 months, we notice that as we grow and develop, we will, when we're separated, like if I have a baby and my baby, and I hand him or her to you, at 2 to 3 months, they're just like, okay, cool, new person, they don't really care. But after about 2 to 3 months, that baby may turn and look back at that parent that they know and start to cry. So they can kind of, vocalize more, cry more for that parent when they're separated a little bit, but not too much. When true separation anxiety happens is somewhere between 4 to 6 months, where they really, you'll notice, and I know you've seen this, where, can you hold my baby for a minute, I've got to go to the bathroom or something, and the baby goes, it starts reaching for that parent as they have to run off, and you've got to do damage control. So we call that separation anxiety, and that's just really happens around 4 to 6 months, where we really identify who our primary caregiver is, and when we're separated from them, we become distressed. After 9 months, we find that we can develop other attachments, perhaps to a grandparent that takes care of us, to a sibling. We really are able to maintain more than one, relationship than just with our parents. So, when we look at attachment behaviors in little babies, and some of our cases will be very little babies, these are the things that we really see that identify that some type of attachment is taking place. So making better eye contact. If I'm looking at a stranger, I may just kind of look at your facial features but not really have much of a reaction. But when I see my parent's face, even at 2 months, if they get between 12 and 18 inches from my face and I'm 2 months old, I know that's my mom's face, even if he or she, they don't say anything. So I'll cry differently, I'll look more, make more eye contact. When that parent leaves, I'll cry and have some kind of separation anxiety. Reaching and approaching. You'll see when kids learn to walk or crawl, if their primary caregiver's in the room, even like walking at crawling at like 10 months. If you're the parent, you're kind of like the base, and then they'll come over here and play, and then they'll come back over here, hang out with you for a while, and they come over here and explore a little bit, and then they come back to their safe place. So really, having that secure base, but then healthfully exploring. And when a stranger walks up, then, you have the kid that hides and clings to the parent. So those are all behaviors that, we don't really think about it, but those are signs of an attachment. So we also have patterns of attachment. I don't want you to stress about this, but it's interesting, and I think, it gives you kind of a basis of what studies kind of show us about different types of attachment. So ultimately what we want is a secure attachment. And there's a researcher about 30 years ago, her name was Ainsworth, and she did a lot of studies of children and their usually mothers in kind of controlled situations where she had the child and the mother in a room, and then the mother leaves the room. I don't even think this study would fly now. I don't think it would make it through a review board because it made them cry. It kind of put them under stress. But she would have the mother leave the room, and there's another adult there, but there was a stranger to the child, and see how the child reacted. And after watching thousands and thousands and thousands, she kind of categorized the way that children reacted. And a lot of studies have come off of that. So what we hope for is a secure attachment. And when we have children with secure attachments, they kind of kept close to that parent as a base. When the parent leaves, they got distressed, and when the parent returned, they're like, oh, phew, you know, and run to them and approach them, and had a clear preference for the parent as opposed to the stranger. So interesting, you know, in general, our general population, 60 to 70% of kids have a secure attachment. But foster kids or children in the foster care system have about a 0.5% chance, so slightly lower than the average. So some other types of behaviors, and you don't need to memorize these so much, but when you see some of these types of behaviors, it may be a sign that the child you're working with doesn't have a great attachment. We have kids that behave ambivalently. They don't use the parent as a secure base. They're just on the run and never care about where there is an adult in the room. And they also are, they kind of notice, like maybe the parent is picking up their keys and their phone and their purse and putting their shoes on. They get upset about that, but once the parent leaves, they're just kind of like, yeah, okay. They're very anxious, and when the parent returns, they're kind of like slow to warm up. They notice that the parent is back, but they don't run to them. They're very slow to warm up and approach that parent as they return to the room. And the anxiety comes from the fact that they never are, you know, perhaps not supervised well or given much attention, so it doesn't make as much of a difference whether the parent is there or not. We also have avoidant attachment where, and these can be kind of confusing, and there's a little bit of overlap here, but there's little emotion expressed when the parent leaves the room, and when they return, there's little response, and there's a very what we call low affect. So if they fall and stub their toe or scrape their knee, normally they would run to whoever is around, an adult, and seek some comfort, but this child really has what we call a low affect or a flat affect, where they're just offering them affection doesn't really change their behavior or their sense of security. They also will treat strangers just the way they treat their own caregivers. So that affection or that seeking of attachment can be very indiscriminate. They can treat total strangers like, you know, they're their best friend. Then there's disorganized, which is, you know, a little bit of overlap of these where there can be more inconsistent, very disorganized behavior. Sometimes I'm happy, sometimes I'm sad. Sometimes I react when the parent leaves or returns, sometimes I don't. There's a lot of acting out, concerns about control, a lot of aggression and fear. So these are the categories that she kind of set out. And again, I don't think you need to stress too much about it, but know that this is what we seek, and when we see these, there may be some underlying behavior or environment. It can also be a result of the child's temperament, but something's going on that may be keeping them from having this secure attachment. And I'll tell you that when we look at the children who are abused and neglected, you see the percentage of this one over here. An abnormally large number of children who are exposed to abuse, neglect, violence, drug abuse in the home, mental illness in the home are disorganized. And that makes it very difficult for folks that work with foster children to understand a lot of their behavior because it's very inconsistent. You know, it's unpredictable. So that's why we feel like it's important for y'all to kind of understand that, you know, if you expect a child to be grateful to you for what you do for them as a CASA, they may not be capable of understanding how much work or how much you care about them because they have attachment issues. Does that make sense? Mm-hmm. Okay. Now, we're going to talk about what's helpful too, so don't think that this is going to be like Debbie Downer conversation this whole time. Okay, so again, I want to kind of emphasize in a little bit more applicable way what a secure attachment looks like versus an insecure attachment. So a securely attached child, as that infant in that little laboratory environment grows up, they are able to form relationships, they're comfortable interacting with others, and they can express emotions in an appropriate way. When we see children that are insecurely attached, they are really uncomfortable forming meaningful relationships. They don't like to talk about their emotions. They're not great with interpersonal interaction. They tend to be kind of isolated. And so when you see those things in it, in the children you work with, it may be a result of just kind of some unhealthy attachment. And these are just a list of, in the foster care system, when we see children with attachment disorders, they may perform some self-soothing behaviors, and a lot of times this is mistaken for autism or attention deficit disorder, or they rock, or, may kind of bump their head against the wall, something that, making little noises. That's their attempt to kind of self-soothe when they're anxious or worried. Abnormal eating behaviors, particularly hoarding food, because they may have been in an environment where they didn't know where their next meal was coming from, and you all may have talked about some of these with other things. But these are things that we see. Inappropriate modeling is where they'll see an adult behave that perhaps isn't the greatest role model. They know that these things are wrong. For example, they've been told not to use foul language. They attach to somebody who uses foul language inappropriately, and so they'll model that behavior. So they do things they know are wrong just because they're modeling someone that isn't a great role model. So those are all things that you may see that are associated with poor attachment. Okay, so we're going to talk about factors that affect attachment. So obviously genetics, and there's probably a lot more we could learn there. But we know that genetically our behavior can be affected by our genes, and also temperament. If you've taken any kind of psychology or child psychology course, you know that the concept of temperament. There are some children that, even within the same family, they have the same exact upbringing. One will be very outgoing and extroverted and makes great friends, and the other one will be very introverted and very slow to warm up. Some people are very adaptable to change. We can throw any kind of life event at them and they just kind of coast through. Others, when we change something like what we eat for dinner, they freak out. So there's a lot of things that affect our child's temperament and their ability to kind of maneuver through the world that are really just who they are. We have a lot of kids in the foster care system who have fragile medical needs, and also, have been diagnosed with mental health disorders. So when that is added to the mix, obviously that can affect attachment. If your child spent the first 4 months of their life in a neonatal ICU and you weren't allowed to hold them for a long time, obviously that can affect attachment. The environment they live in, the environment that surrounds their home, and obviously the parents and caregivers. Those are all things that can affect attachment. Some other studies show that caregivers who are very critical, very controlling, very interfering, can have children who kind of avoid emotional intimacy with people because they're afraid of that rejection continuing. There's a lot of inconsistency in emotional attachment when children are exposed to abuse, neglect, and those types of things. I thought you had your hand raised.
No, I'm not asking any questions.
No, that's okay. Okay, so there's two more terms that I want to introduce you to that you may see, especially in children's records. And those are kind of, you hear about the DSM, which is like the giant book that psychologists and psychiatrists use that tells us all about the recognized mental health disorders that are out there. And these are two that I want to introduce you to that are specific to children. And they're specific to children who have undergone, abuse, neglect, difficult life situations. So the first one's called RAD, and that's reactive attachment disorder. So before age 5, if a child has experienced emotional, physical abuse, neglect, or a big change in caregivers, they were removed from the home, maybe they weren't exposed to that, but they had to be removed from the home for some other reason and they had to change caregivers. That has to be a defining characteristic. That has to happen. They have to have been through something bad, and they have it, as a result, developed an inappropriate emotional attachment with caregivers. So these kids will have that very flat affect, low affect, where they just seem like they don't really respond much to anything. Their emotions are very dull dulled. You know, they don't smile, they don't cry, they don't have any extremes, they're just flat. And they're not cuddly, even with their biological parents. They don't seek comfort when distressed. They're so used to feeling distressed that they just don't even seek comfort for it anymore. And then there's also developmental issues like speech and gross development, fine motor development, meeting milestones about being able to crawl and run and jump and play. And peer relations aren't great. And then there are episodes where their emotions will all of a sudden kind of go all over the board. So again, this has to happen in association with some type of removal from the home, neglect, or physical abuse in order for this to be the diagnosis. And it's frequently misdiagnosed, as you can imagine, as being autism or some type of ADHD, when in actuality it's really a result of their life circumstances. Did I see a hand up? No? Okay, so the other one that I want to talk about that can be kind of confused with RAD is where a child inappropriately interacts with unfamiliar adults. And the more you learn about kids in the foster care system or children who've been abused and neglected, you'll hear a lot of cases that are like this, and you may witness one where a child has absolutely no fear of strangers, even at that early age that we were talking about where they develop that stranger anxiety. These children will really, they're over-friendly, over-trusting, will jump in a parent's lap to the point where, you can say, I've been around kids a lot and I don't see that type of behavior as being typical, where a very young child, a toddler will just run to anybody and want to be their best friend. Most kids are wary of people that they don't know. So it gets to the point where the foster parent, the person whose lap they're climbing into, it may be you as a CASA, they're like, this is uncomfortable, And as they get older, it may continue where you have a 12 or 13-year-old child who may jump in the lap of someone who is of the opposite sex or gender, and it makes that person uncomfortable. So it really is a very almost inappropriate amount of attachment and interaction with complete strangers. We see that when we look back at children who were in orphanages where there was a large group setting of lots and lots of babies, they tend to, for whatever reason, they tend to display this disorder a lot more than other children. So, the main difference that we see between RAD and DSED is that kids with reactive attachment disorder are just very, flat, almost depressed all the time, and are very internalized. They kind of keep to themselves. They may not express their emotions. They're very flat. Whereas the kid with DSED is extroverted to the extreme, very externalized and expressive and almost manipulative in the way that they approach people to try to get them to like them. Okay. So those are the big kind of two ends of the spectrum in terms of disorders that we see in terms of attachment with kids that are experiencing abuse and neglect. But one thing to keep in mind is what sets these different from other disorders that sound like them, or that this behavior may sound like, is that there was some social neglect in this child's life. Okay, that's the defining characteristic of these. Okay, we have talked about separation issues and the fact that every child that we work with as a CASA is experiencing some type of separation. And we know that it's normal for children to, to really, this is 4 to 8, not 48. All children should develop stranger anxiety between 4 and 8 months. So any child who's older than that is really going to experience a lot of separation. So when you see a child who's been separated from the home or from their parents, from children, other siblings, pets, these are the things that we really do expect them to experience and to demonstrate, which are, very fearful and anxious. If they have been removed from the home more than once, which we see often. For example, if they were removed from the home because they had a parent who was dependent on drugs, the parent becomes clean, they get to go back home, and the parent starts using again. They know that that's what got them removed from the home the first time, so they become profoundly anxious, afraid, trying to fix everything, because they know that that means they're going to be separated from their home and their family again. Even after they're removed from the home, they worry about what's going on at home, or is my dog or cat okay, or my siblings okay, if they're not with them. They worry about getting lost and getting kidnapped, and they won't go to school, and they won't go anywhere that's not a familiar place for them. There's just a lot of fear and anxiety and separation. They won't go spend the night with somebody or go to a summer camp or anywhere that's not familiar to them. They can even have headaches, stomach aches, bedwetting, actual physical complaints as a result of this separation. So there's a lot of signs and symptoms of separation anxiety that you'll see that you got to just know this is what's causing this, and we'll talk about what we can do to kind of fix it or to help the child. So one thing that's really important is to kind of turn the coin a little bit and talk about, thinking about kids that don't fit that mold. There are a lot of kids that, in general, I can tell you from years and years of working with kids who are in very acute situations, it is amazing to me how resilient children are in general. Situations that would have you and I in a ball in the corner for months, a child will wake up after experiencing a traumatic injury, a traumatic event, and once they're physically well again, a 3-year-old is being a 3-year-old, a 5-year-old is being a 5-year-old. They're playing with their Matchbox cars. They're doing the things that you and I as adults would not be. We wouldn't be able to go to work. We'd be a hot mess. And kids are just so incredibly resilient and just being back to themselves in spite of great deal of adversity. So one thing that's important to look at, because we want to focus on the strengths of the children that we're working with, not how terrible their experience is all the time. So when you think about the strengths, when we look at kids who are extra resilient, this has been studied a lot too, and children who are resilient tend to be firstborns, or only children, meaning they kind of paved the way. When we talk about temperament, and I talked about an easy child versus a slow to warm up or slow to adapt to change child, it would make sense that child who adapts easily to change would be more resilient. They have a positive, a secure attachment with that parent. They do well in school. They have a good support system. So these things listed here, when you see those things in the child that you're working with, those are strengths. And so, for example, if you notice that they have a sense of humor, or they have plans for the future, they say, I want to be, a firefighter, or I want to be a doctor, and I'm trying to do well in school so I can go to medical school. Those things you got to put in your mind, this is a strength. I need to work with this. I need to make sure, for example, that if they have a good relationship with people at that church, that I do everything I can to let them make sure that they can stay close to that church. If they have a great relationship, maybe not with their parents, but with a grandparent, you want to do everything that you can to try to foster that relationship, because that is a strength and that is going to give them resilience. So kind of keep these things in your mind, and when you see those in children you're working with, know that these are things that are associated with resilience and being able to really overcome in spite of their circumstances. Okay. Some tips for building resilience. These are also, if you don't see a lot of resilience in the child that you're working with, these are the things that we can really do. And these are from the American Psychological Association, and it's really just for parents in general. How can I make sure that my child is a resilient child? These are the things that really help children to really bounce back in spite of adversity. And if you look at them, having them help, teaching them self-care, moving them toward their goals, it's about empowering kids. When we do everything for them, they don't learn to overcome adversity. When we give them little jobs, the little chores, even if it's as simple as helping you, pour milk in their cereal as a very young child, or helping you a child make dinner. And we teach our foster parents this as well, that one of the best things you can do for a child who's in an acute and very distressful situation is to give them ways to help themselves, and that makes us feel good. You know, it gives us power over our circumstances. So, again, you know, when you're working with a child and you want to make sure that you foster some resilience in spite of some difficult situations, these are things that we can do for them. Okay. So, what does this mean to me? We're not asking you to diagnose DSED in a child. We're not asking you to fix unhealthy attachments. I don't even know if that's possible. What we want to do is help you to kind of apply some of this information to your job as a CASA. So when you are given the gift of working with a child and you learn more about that child, make sure that they have undergone some good assessment by a mental health professional, where they've kind of been assessed and the professionals figured out if they have healthy or unhealthy attachments, what types of behaviors are they experiencing, how are they responding to separation, because we said everybody's experiencing. Is their response healthy or is it somewhat troubling? What can I do to figure that out? So first of all, if they don't have great therapy that you can find that they've been assessed, let's push for that. Sometimes you get a child right as they're entering the foster care system and they haven't really been in the care of a mental health professional to figure out how they're coping. So if that hasn't happened, advocate for that straight off the bat, because that's something you will use, that's something the judge will use, that's something that the social workers and CPS caseworkers will use to make sure that their needs are being met. You can see some of these other things. When we talk about separation anxiety, that is so acute that a lot of kids, anybody that they meet, including you, when do I get to see my mom? When am I get to see my dad? When am I going to get to see, when am I get to see them? That's all they care about. You can't have a conversation with them because all they want to know is, when do I get to see my parent again? So we want to be very honest with them. We can't ever say, I promise you're going to get to see her on this date that we've planned, because something might happen and that date might fall through. The judge may say that the visitation can't happen for whatever reason, and so we've broken that promise about that child. So we want to be honest about what we know about when visitation is going to take place, because that's often the first thing the child wants to know. But again, don't make promises about it, because things can happen, and then that trust in us as a CASA is lost. Have you guys talked about continuances yet?
Not really.
Okay, so we want to avoid those. When we have a court hearing regarding a child's case, where they're going to live, where they're going to be placed, a continuance is when it's delayed because things aren't ready. Maybe CPS's paperwork isn't ready, or the mental health counseling and assessment hasn't taken place. All the paperwork or all the legal stuff that has to be ready for review by that judge isn't ready, and so they say, okay, we're gonna have continuance. He or she is gonna stay in the group home where they are, or sometimes it's not an ideal or great permanent place where the child is. Well, they're just gonna have to stay there for another couple months while we get everything together to review their case. We want to avoid that at all costs, because every time, and the more a child's in the foster care system and the older they are, when they learn there's a continuance, they know that means, nobody's figured out what to do with them yet. And so we want to make sure that when we know that there's a hearing scheduled, we want to do everything we can to make sure all the ducks are in a row and ready for that to take place. That's us advocating for our child as a CASA, is to make sure that we avoid continuances at all costs. So you got to get on the phone, you got to be a squeaky wheel. If you know that there's an element that's missing in order for this child to achieve a permanent placement, we want to get on the horn and try to make sure that duck is in line with all the rest of them.
That makes full sense,
Mhm.
but it apparently also a lot of movement, a lot of placement, replacement, etc. can cause problems too. So,
Right. The way the system sometimes works is that when when there's a court hearing, a lot of times that's establishing at least a It may be a short-term situation. When a child first enters the foster care system, they may be placed in an emergency placement where, somewhere that a child really, it isn't ideal for them to be for more than a month or two. If a continuance happens during that period, that child is left in that not ideal environment for longer. If a court hearing can happen where we can say, okay, we're gonna place them in this foster home for 6 months, or, whatever the time is, that we tend to see less movement after, once a court hearing actually takes place. The more continuances there are, the more we have to shuffle kids around.
It's interesting because we saw a court case last week that involved a rather unusual set of circumstances. And it ended up being, I think, part of an issue being a placement that might result in taking that child away again because it really wasn't the ultimate and proper place.
Right.
Versus doing and placing that child in something where there was perhaps more indication that permanence could be achieved in that placement.
Right.
So as CASAs, and CPS couldn't change their recommendation because they're bound legally. So it's kind of a situation where we as CASAs have to really assess that.
Yeah.
And keep in mind, too many placement movements versus, as you said, keeping a child in
Was this
overlong
a,
in one place.
yeah, was it a real case or was it
Yes,
like a
it was
case
a real
study?
case.
Okay.
Yeah.
That's
Why
interesting
we-
because it sounds a lot like the case. Well, it sounds a lot like the case study that we're about to talk about. And it illustrates that it's not always black and white. It's not always clear to you, much less everybody else involved, what the best decision is for a child. So, that's a great question. So, when you do see a healthy and a secure attachment between a parent or caregiver and child, and it does them good, then we want to advocate for as much visitation as we can. There's a lot of times that we're not looking at outright physical or sexual abuse, we're just looking at life circumstances that require a child to be removed from the home, but they have a healthy attachment with, and it benefits that child to be with that parent. If that's the case and you see that, then that is a source of strength. We need to push for that visitation as much as possible. So, and the other two are really just kind of general. We want to gather as much information as we can that's accurate and evidence-based about what's going on with the child, not the rumors, not the neighbor that Mrs. Kravitz. Some of y'all are too young to remember Mrs. Kravitz. And if you ever watch the show Bewitched, she was this lady that was always looking up. And then advocating for permanency. That is the ultimate goal, is to get a healthy, permanent placement for a child, whatever the best thing is for that individual case. So, please don't feel powerless with some of the things that we're telling you about the behaviors and the outcomes that these children have, because the things that we can do as CASAs can absolutely change that child's trajectory. You have a lot more power over benefiting a child's life and their future than you think. And that's really the great value of being a CASA and being that way. Treatment for attachment issues. If you do see issues with unhealthy attachment, these are the things that we need to see, and the biggest thing is a permanent, healthy placement. It doesn't have to be with the parents, but for them to be in a stable, loving home environment that doesn't change all the time, that is the way to get healthy attachment behaviors, healthy future relationships. Parents or foster parents or adopted parents who are psychologically stable and able to, commit to being a parent or caregiver. And then a great therapist, whether it's a psychiatrist, a psychologist, someone who specializes in children and in their attachment issues. That is really essential for these kids. And that's one of the big problems we have in our area is we have a lot of kids who need that therapy, and we don't have enough therapists in this area. So a lot of them are having to go to Houston, Austin to get therapy. And you can imagine, the challenges and barriers that creates.
So CASA doesn't actually recommend therapists, though, do
We can
Or-
recommend therapy or
like,
increased visits.
do a referral.
Oh, okay.
Right.
Yeah, yeah, that would be something, I'm not, most of us, I don't think many of us know about.
Right. It's not our role to say a specific person, but to make sure that, for example, Child Protective Services and the the legal advocates for that child, make sure that that gets done, is important for us to do, yeah. Okay. All right, other things that are good, important things to advocate for separation issues are listed here. So talk and play therapy. Things that we can do are to teach the kids ways to deal with stress and anxiety. And over the age of about 5, kids can learn those, meditation, deep breathing, especially if it's right before a big event, like a visitation with a parent they haven't seen in a while and they're scared of what's gonna happen, or maybe they have to testify in court. We hate to do that to kids, but that might happen. So we can empower kids by kind of showing them ways of dealing with stress like these things here. These are all kind of issues that can really help us to help the kids that we take care of that have those separations.
What are cognitive coping methods?
So those are things that we teach kids, well, adults too. When we talk about going to see a therapist and them teaching you kind of cognitive behavioral therapy, so if you're very anxious about an upcoming event, you can journal about it. It's like a conscious kind of a thinking and behaving or reflecting on my thought process. So for a young kid, it can be asking them, kind of simple questions about how they feel about what's going on, and what's something that you think you can do to help yourself to feel better. For an older child or an adult, it can be journaling, it can be self-talk. We talk a lot about that inner voice. And I'm not talking about the schizophrenic voice. I'm talking about that inner voice that we all have that says, I'm gonna have a good day, or this day stinks, or I'm gonna ace this test, or I'm gonna bomb it. Sometimes reframing that inner voice, even in kids, can be helpful, kind of changing their thought process to a way that's healthier. So that's what that coping method is talking about. Does that answer your question?
Thank you.
All right, so questions about, I know it's a lot of information, but it kind of gives you an idea of what these kids are going through. Yes, ma'am?
I was wondering, so what if the primary caregiver is, say, a grandparent or something? Is visitation where the grandparent is something that we could also advocate for? Is that something they do?
Right? Yeah, absolutely. And sometimes, there's a grandparent that's involved with the child, but maybe they don't live really close, or the child is placed somewhere that's further away from where that grandparent lives. And if that's a healthy, attached relationship, then we want to advocate for them. Maybe they don't have a car, maybe there's a difficulty in getting the grandparent to where the child is, but we want to try to meet those challenges so they can see each other. Other questions? Well, I want to end with a quick case study, and it's interesting because it sounds a lot like, y'all may be really good at this because you may have been exposed to a case like this. This is actually a kind of a case study that's based on a real case. It's from the CASA organization in Dallas. So I want to just read it to you. It's not up on screen since it's a lot of words. So I want to read to you this scenario about